Welcome to this first main program session of Rhythm Interventions Online 2025 US Focus. The topic for the session is tackling persistent redo AF with pulse field energy. Before we take a look at the case, let's meet our faculty. We're delighted to welcome Frank Cuoco from Charleston, Moussa Mansour from Boston, and Andrea Natale from Austin. Now, to start proceedings, I'm going to share a case recently recorded at my center, St. Bernard's Medical Center in Jonesboro, Arkansas. Can I have my slides, please? All right, so for this session, what I'm going to do is actually share a case from the rematch study. And it is my privilege to have Dr. Mansour, who is the national PI for the study, as our faculty panelist. These are my disclosures. What we'll do is we'll go through just a background on the rematch trial, and I'll talk a little bit about the focal PFA catheter that's being used in this trial. We'll discuss about my zero fluoro workflow that I use with ICE and mapping through this recorded case from the rematch study, and also talk a little bit about some of the next generation mapping software with contact sensing and lesion tagging that we're starting to utilize in these cases. So just a little bit on the rematch study design. This is a study to evaluate the safety and effectiveness of the FARAWAVE and the FARAPOINT catheter for redo ablation in persistent AF patients. About 50 sites with about 276 subjects are being enrolled. These patients undergo redo AF ablation with electroanatomical mapping. What is required is a PVI, but the operators have the opportunity to do posterior wall ablation, CTI ablation, or mitral isthmus ablation as needed in cases when it's needed. And the follow-up is through 1 year. And the one thing that is, I think, very interesting is that these patients will be followed with a Lux ILR monitor for passive data collection through the 30 months. Now, the initial AF ablation in these patients would have been within 5 years prior to enrollment. And one of the newer catheters that is being used in this study is the focal PFA catheter, the FARAPOINT catheter. It is a biphasic bipolar PFA system that delivers PFA from all 4 electrodes for about 2.5 seconds. And you can use the catheter in different configurations and you'll see that through the case recording, how we use this catheter. One of the things that you'll see with this catheter is it can be, the way the lesion is dependent on how the catheter coincides with the tissue. So it can be perpendicular or parallel, and you get a different lesion morphology when you use this catheter in different positions. And this catheter was previously used in the Advantage Phase 2 with a 96.4% CTI effectiveness endpoint, and nitroglycerin was used when pulse field energy was used in the annulus region. The one thing I do want to bring up is also the use of pulse field energy versus radiofrequency energy on a chronic RF ablation substrate. So if you look at this bench model, you can see that on retreatment of PFA over chronic RFA or acute RFA, you'll see that the lesion depth is pretty similar, whereas if you did acute RF over chronic RF, that depth was not as great. So a PF over RF seems to be effective and could penetrate scar easily. And just a little quick on the lesion depth from this focal catheter, what we'll be delivering is about 2 kilovolts, 2 applications per site in most of these, and you get about 4.5 millimeter lesions in the preclinical data. But what I want to also say is that if you actually apply about 4 applications, you could potentially get about 7 millimeters, which in the atrium, that's not as big of a deal. So real quickly, let me introduce the patient. It's a 74-year-old female who's got multiple comorbidities, had a cryoablation in 2022, has been off antiarrhythmics on OAC, had recurrence of persistent AF in 2025, required cardioversion, again had recurrence with atypical atrial flutter with a higher conversion on higher dose of sotalol, currently being maintained on amiodarone due to bradycardia. So let me just walk you through the case. So, sorry, if you could just go back and play that. Thank you. So here you can see I get my access usually with ultrasound. I usually use pre-close. This is all standard of care for me. we'll get, and most of our patients actually go home the same day, and the study allows us to do that. So we're using, as I said, the FARAWAVE system, and I'm using the FARA Drive sheet, and we're doing a mid transeptal. I like to take my ice into the left atrium. That is standard of care for me, and it's mostly for visualization. I don't use fluoroscopy for my procedure, so you'll see I'll take my ice catheter into the left atrium. You can see we're rewiring or we're wiring the left inferior pulmonary vein. We'll do a quick, I'm not doing a high density voltage map here. This patient only had a PVI. We're just going to do a quick voltage map to get an assessment of what the PV durability looks like. And you'll see, I mean, it maps through the 5 electrodes that's out there. And you can see the yellow lights that are coming on are contact sensing. It's a new contact sensing software with the Opal system where it's based off of impedance. And with the delta impedance, it senses contact and lights up. So it's a visual cue to know that you have contact. But also you can see on ice that I have a pretty good understanding of where contact is. And but what we'll do is we'll do a quick kind of LA map. And Dr. Mansour and Dr. Cuoco and Dr. Natale, if you want to jump in, feel free to. But we're just kind of taking the catheter and doing a quick map. I don't spend a lot of time. The study protocol actually allows us to do lesions over the PVs again, and actually encourages us to do at least flower lesions over the pulmonary veins, even if the veins were durable, mainly because we've seen that PF over RF is good or thermal is good, and we want to kind of reinforce that PV durability in the trial. So in this case, you can see on that map, there was some reconnection in that left superior. Yes.
David, no, I want to ask. So this is not a. I think in the future they are planning to have a device with more electrodes than what we. So this is still the same device, right? So the quality of the recording is not.
This is still
that great.
Yes, yes,
Yeah.
it's a great point.
So
it is. This is still the commercially available catheter.
Yeah. So, Andrea, I think this catheter is good enough for anatomy and for finding
for the anatomy, yes, but I'm talking about, this eye. Yeah, I no, no, for the anatomy, I have no doubt, but I'm concerned about how confident you are about the quality of the electrode and to decide if there is a reconnection, because you see a lot of far field with those electrodes.
Yeah.
From here,
so I was about
you'll see though. We're going to give lesions in the pulmonary vein anyway, Andrea. So if you look at it, I'm actually doing my ablation along the left inferior. I'm going up to the left. I'm actually starting in the right inferior. So I finish mapping. Usually, for most cases, I start on the left. Inferior, yeah. But in these cases, because I finished, I finish in the right inferior with mapping, I just start ablating there. So the right inferior was actually isolated. We didn't have any exit block either. So this is before I did any ablation. So there was actually exit block, but I still did a flower lesion to kind of get a nice antral application in that right inferior and to widen that right inferior footprint. The cryo is it was a 31 millimeter balloon. So with this one, this is also a 31 millimeter catheter, but I can do a more segmental kind of approach with the flower configuration. Now this contact thing that you're seeing there.
Devi, can I say one thing?
Also.
Yeah, please, please.
So Andrea, part of the protocol that is to encourage doing antral isolation with the flower configuration, even if the veins are isolated. So I was about to say earlier, yes, it's good for anatomy. So if there's any doubt or anything, it's a small step to put few more lesions with any configuration. But we're planning to do, part of the study is to do the antral isolation or ablation on everybody in the study.
Yeah, so in this case, on the pre-map, only the left superior was reconnected, and it was very hard for me to believe that could be the reason for the recurrence and the atypical flutter. So we decided to do a posterior wall ablation as well. Now, remember, posterior wall is optional in the study, but here you can see I've finished the right veins, and I'm kind of stamping along that posterior wall. Andrea, you asked about how confident I'm about the contact sensing software. Remember, it's only off of one electrode, right? So there's always that caveat, so you have to keep that in mind. But I'm looking on ice, right? So I'm confirming on ice that I have contact before I give every lesion.
Beautiful picture on ice. Yes. Yeah.
Yeah, Yeah, I mean, the ice is in the left atrium, and you can clearly see. I'll rotate back and forth. It does have a pretty reasonable correlation, but I would caution people that you still have to have another adjunctive tool. I think to make sure. To me, I think this tool is useful in countries that don't have access to ice and they're using fluoro. So I think that's a much. I think it's a good combo. But I don't know, if, Frank, what's your have you used this software as well?
Yes, pretty extensively, and like you, I also have a zero flow workflow. So I think using the ice to correlate the contact is good, but I think that there are sometimes, as you know, even with left-sided ice, you may not get a good visualization of one pedal, or you're trying to correlate. Hey, do I have a good field tag along with my contact on the catheter and ice? I think all of that information together is really helpful to make sure that one, you have good contact, and two, you're delivering a good lesion there. So I agree. I think this software is useful, and I think it's the right step in the right direction. I mean, I think it's going to improve, as Andrea mentioned, when the catheter changes and we're going to be able to map off all the electrodes. I think it'll be much more useful.
Frank. Yeah, I want to jump in here because I want to just show one of the things. So here you can see we're actually in some kind of AF organized atrial arrhythmia there, and the patient came in that rhythm. But I'll also actually there, you start seeing it starting to organize as I finish the posterior wall, and we actually terminate on the roof there. Now, termination, we're obviously happy. You can see I'm happy there, but this is a patient that we could not convert. We're like joyful people. Let's just be clear. But here's the point is, you can't really. I don't know how much we can trust termination in the world of PF, right? It could be the local cardioversion. But having said that, when I see termination, I guess there's circuit nearby, maybe. I don't know. So I actually will give an additional application. I'll also actually look on ice if I see that the tissue is thicker, because that particular area, the roof of that left superior and the posterior aspect is usually pretty thick. I might actually do a little more overlap. I don't go by just the lesion tags turning red. And here, actually, I'm doing these ankle lesions. So what I have is I have to wire in the left inferior. Because this patient had atypical flutter, I decided to a mitral line as well. This is a second time, and I knew I was not going to get her back into the lab. So we are, Andrea recently published data on the mitral isthmus and durability of mitral isthmus. And I think this is where I kind of want to jump in. So I did lesions with the flower, but what I did is I tracked those lesions. Those white dots are just where I did the shaft of where my flower catheter was. Now we're coming with the Farah-Point catheter. So with this new software, you can see the lesion tags on the Farah-Point. So I'm actually perpendicular. Of course, you have no contact assessment on this catheter. So you have to use ice to make sure you have contact. But you can see when you come perpendicular, you get the kind of that circular lesion tag. My lesion tag right now is 5 millimeter. Now, I will start at 5, and you'll see, I kind of stack it. I overlap my 5 millimeters. Mostly because of the data that we know this area is thick and it requires a little more depth. And like I showed on that lesion depth, you get about 4 millimeters, but if you get about 4 applications, you can get up to 7 millimeters. So in this area, I definitely do a little more stacking. And you can see I shrunk the size down to like 3 millimeters, and I'll see if there's any areas left behind, like if I didn't stack enough. I could start at 3, but that's a whole different question. But
what
we're actually doing is also, yep. I was going to get to the CTI and then actually come.
Can you?
So here we are actually doing the CTI.
Your approach for nitroglycerin?
Yes, absolutely. But before I get into the nitro, here you can see the catheter is now parallel to the tissue, and you can see the lesion tags are different, right? So they are more elongated because now you got delivery through all 4 electrodes. And like Dr. Mansour mentioned, so when we are at the annulus, whether it's a mitral isthmus or the CTI, there is a mandatory nitro protocol. So I usually, what I do is when I'm doing my ankle lesions, I start my ankle lesions along the left inferior pulmonary vein, and I go towards annulus, and I give 3 milligrams of nitro, usually pre-treat with some phenylephrine. We treat with 3 milligrams of nitro. This is from the Advantage protocol, and it did well for us. We didn't have any spasm with the nitro use, so we kind of use that same protocol. So we'll do 3 for mitral, and then by the time I get to the mitral isthmus, that 3 would have kicked in. So usually about a minute after the nitro is in, I'm ready to do that application. Here you can see I'm actually coming. There is a little eye on the ice. You can see there's a little nook, crevice in that CTI. So we're actually doing not just a straight linear lesion, we're coming down and reinforcing that area. And I think to me, this is where ice is so valuable, right? You're not going to see this stuff on fluoro. And so maybe you don't need it, but I feel like this kind of gives me a little more comfort. But this is just that lesion set just played very quickly. But what I was saying is if I'll finish the mitral with 3 milligrams of nitro. When I come back with the FARAPOINT, if I just given the nitro, I'll start on the mitral isthmus. But if I'm giving nitro fresh again, then I'll start on the pulmonary vein. So I usually wait about a minute before I ablate along the mitral or the CTI. And again, we'll check for bidirectional block, both for the mitral as well as CTI. Now, we definitely have seen
Devi,
with this.
Devi, I know you. I'm sorry to interrupt. When you do your nitro, and practically speaking, when you're redosing the nitro, do you change your protocol or change your nitro delivery based on your proximity to a coronary? Do you use the ice images? Because obviously, as you know, a lot of times you can see those coronaries pretty well on ice.
So I will say that yeah, absolutely. I think the left. I think you see the circumflex, but anytime I'm anywhere getting close to the annulus, if I see an A and V, I'll actually do the nitro. I do 3 milligrams for the left, and I do 3 milligrams for the right. And then you can actually, after 3 minutes, you can actually redose 2 milligrams. I've not had to. The CTI and mitral lines are pretty quick. I mean, they're 2.5-second lesions with a point catheter. And even though it looked like I was stacking a lot, I mean, they're pretty quick lesions. So I've not had to redose. But I'm sure if I have to, I wouldn't mind.
So Frank,
so you want to
Frank for the nitro, we wanted to follow the Advantage protocol for the study. So yes, I know in clinical practice you may want to be a little bit more selective when to give nitro, and maybe you want to assess the location and whether you're on top of the coronary arteries or not. But obviously, in a clinical trial, you cannot. You need to set some type of standard and homogeneity on how the procedure is done, so we will get the same approach for everybody. But in practice, you may not need to do that for all patients. And I think last time I was talking to Andrea, he mentioned he doesn't do it probably at all. He waits until he sees any EKG changes. So there's a variation in how nitro is used with pulse field ablation, but we wanted to be conservative for the study and follow the Advantage protocol.
Andrea, let me ask you something. I mean, so you just published the data, right? You just published the durability data for mitral and for the mitral lines and how it's not the greatest with the pentaspline catheter. Do you see this kind of workflow with reinforcing with the point PFA maybe making a difference?
Yeah, I mean, I think if you really get to 7 millimeter, I think is yes, because the issue with the pentaspline is that the lesion are about 4.5, the same what you mentioned with the one application of bipolar. I think eventually that catheter is going to become monopolar, and with monopolar we're going to see better lesion quality. But right now I think you have to rely on reinforcing the lesion, and if you really get to 7 millimeter, you should be okay. Yeah.
So Devi, if I make one comment here, I think when we talk about the mitral isthmus line, there are two aspects. One of them is whether PFA has any limitation or not when it comes to lesion depth, and the other one is catheter contact. I think the biggest advantage that the FARAPOINT brings is the contact with the tissue, because no matter what you can do with a FARAWave catheter, it's really hard to have it well positioned, and you might end up with gap. And we always suspected that, and then Andrea published that recently. I think the Farapoint catheter will solve the issue of contact and lesion depth. No, the issue of contacts and gaps. And if you, as you said, we use the same approach that you described, stack lesions, knowing that the you're really not risking much by stacking lesion, and this, I believe, will give you the depth that you mentioned and Andrea mentioned as well.
Now, Frank, let me ask you a question on the Opal software and ST changes. You know, we've recently started using the Opal mapping system and their 12-lead EKG to kind of keep up with the ST changes. We've started to see that it seems to be a little more sensitive than my recording system 12-lead. You know, we have it stretched out all the way to 150, and sometimes you just don't see it. But the 12-lead on the Opal seems to catch it sooner if we are starting to see any changes.
Absolutely. I like that software. As you know, when we're looking at things at 200 sweep speed and the QRSs are flying by, it's very hard to sometimes see very subtle ST changes. But the Opal software actually has a very nice feature where it can you can set your template as to prior ablation, and it shows the EKG and then superimposes the live EKG over your baseline EKG. So as you're delivering lesions, you can start to see subtle changes in ST segments. And then, that may or may not obviously influence you clinically to either deliver more nitroglycerin or be aware. I mean, I like Andrea, sometimes have not in my non-study cases. I don't always use nitroglycerin if I don't see the coronary and I'm not near the coronary. But I have had one or two cases where we did start to pick up on that, and we were able to deliver nitroglycerin right away, and then that ST segment change quickly resolved.
And that's something important you mentioned, because in most lab the setting is 2 or maximum 4 ECG lead. It's very important that people, if you want to detect ST change, you need to look at 12 lead ECG. This is a very critical question, and I think some of the cases where people miss it and then they say it's delay, I think partially I feel it's because of that. So the 12 lead ECG is a very important tool. You want to look for ST changes.
It's obviously it's hard to see it on the recording system. So what I do, I always I talk to the anesthesiologist all the time. They see it easier on their monitors. It's like a standard speed, and they can put all 12 leads. And sometimes we have a secondary monitor that's it's other than your main EP monitor that the anesthesia use for hemodynamic monitoring. So I use that to look at the ST segments. I find that very helpful.
Okay, so let me ask you something, Andrea. So I think one of the things that both you and Frank kind of mentioned is that you don't routinely give nitro for your commercial cases. Now, I just don't have the guts to do it, so I actually give nitro anytime I'm near the analyst. I try not to take pulse field energy to the analyst if I can avoid it. But if you do not have nitro, if you're not giving nitro proactively, what are some of the things that you would actually tell our audience to kind of watch out for, other than just watching the 12 lead, but just like the logistics?
Yes, watching the 12 lead is one important thing. And also the nitro has to be available in the room. It's not like I need nitro, they go leave the room and go and get it. It has to be in the room because you need to give it. Because sometimes, when you have a ST elevation, you quickly degenerate into R block, you can have VF. So when you see some changes, the nitro has to be there to be given. So no delay, not even 5 seconds. It has to be in the syringe, you give it. So this is the way we do it. So we actually, before we start ablating in those areas, we ask the nurse, is the nitro available? And they say yes, and then we go. And, I mean, the bottom line is that when we look at our occurrence of ST change, is very rare. So to give nitro to everybody is probably we're certainly overdoing it. But as long as it's there available, I think so far has been safe. We didn't have any problem. and it's a good workflow.
And I do pre-medicate
Moussa,
too
let me ask you.
with some neosynephrine so that way they're ready for
Yeah.
if you are going to give them nitro, you're not going to drop their blood
Yes.
pressure too severely. It'll be low, but not that.
So Moussa, let me ask you a question on the mitral line. So I know I did a posterolateral kind of mitral line. Can you talk a little bit about your approach to mitral isthmus, and how often are you doing alternate lines, like anterior lines or lateral lines? Like, can you talk about it a little bit?
Yeah, so I think the posterior mitral isthmus line is the easiest because it is the shortest distance. The only time I do an anterior mitral isthmus line if the patient have a significant scarring in the left atrium, and we see it. This is an area prone to scar formation, and you see like the scar is almost reaching from the mitral isthmus all the way up to above the appendage, and in these patients. You need to do very little ablation to continue to achieve anterior isthmus block. So I scan with the catheter a little bit. I put the catheter anteriorly, the FARAWAVE, see how much voltage, how much scarring we have. And most of the time, we end up doing a posterior mitral isthmus line.
What about the
risk?
risk?
Do you ever worry about the appendage?
Yeah, sorry, same question.
So the appendage,
then,
if you do a posterior mitral isthmus line, so first of all, in these patients, because of the amount of scarring, the conduction into the appendage is already affected, and it's just hanging by a thread. And if you don't do a posterior isthmus line, I don't think just doing an anterior line will isolate the appendage. You don't want to do both unless you're doing it on purpose.
Yes. Yeah. I totally agree.
And I'm sorry.
No, I totally agree with you.
Moussa, can I ask you a
But in the
question?
event of doing it,
it's a little too late.
Yeah, I guess
I'm sorry. Go ahead.
No, go ahead.
Once that happens,
go ahead, Frank.
Once that happens, I mean, I think we all have cases where some of these flutters are very, very tough, and you do wind up having to go both sides. Andrea, I know you probably feel very strongly about this, but once that does happen, if you do wind up with isolation of the appendage, which does tend to be very effective for eliminating the flutter long term, but then is your approach long term to close the appendage? Or do you feel that it's safe for patients to continue anticoagulation?
No. When you isolate the appendage with a wide area around it, if you do, like, let's say you start with a posterior isthmus line and you end up doing an anterior isthmus line, you're not only isolating the appendage, you're almost isolating like maybe half of the left atrium. And these patients become very heavily dependent on anticoagulation. I had a patient went to a dentist, just stopped Eliquis for like 1 day, and they had a stroke. Luckily, it was minor. So not only I bring these patients back for an appendage closure device, but I keep them on anticoagulation in addition to the Watchman, because most of them, they don't have an indication for bleeding. So I keep them either on, maybe this would be a good population to keep on half dose anticoagulation, even with the Watchman procedure.
Yeah, this is exactly what Moussa mentioned.
Well, that's all the time we have for this session. So our thanks to Frank, Moussa, and Andrea. Join us for our next session starting in just a minute. Thank you.
Thank you.
Devi. Bye.